So think about it like this. If you get, say, a cosmetic regenerative treatment on your face, and it swells up a bit, you basically just look kind of puffy for a few days, right?
Right, yeah. You throw on some ice, maybe grab your oversized sunglasses and just sort of wait it out.
Exactly. But if that exact same regenerative treatment causes severe swelling in your most delicate, intimate anatomy, well, you might actually end up in the emergency room, literally unable to empty your bladder.
Yeah, the anatomical context completely changes the landscape of risk here. It's wild.
It really is. So today, for this deep dive, we are exploring the rapidly growing world of intimate polynucleotides, which, if you're not familiar, are these highly purified DNA fragments used for vulvovaginal tissue regeneration.
And to really get to the bottom of this, we're pulling from a huge stack of clinical safety reports, aesthetic medicine protocols, and specialized women's health clinic guidelines.
Because our mission today is to figure out exactly what long-term surveillance benchmarks clinicians use to monitor tissue stability and safety, especially following repeated cycles of these intimate injections.
Right, because when you're constantly signaling cells in such a sensitive, structurally complex area to regenerate over, years and decades, you absolutely need a rigorous system to monitor that newly generated tissue.
Definitely. But, I mean, if you're listening to this and wondering why on earth someone is injecting DNA fragments into their most sensitive anatomy, we kind of have to look at the underlying biological timeline first, right?
Oh, totally. You really can't understand how doctors monitor the long-term safety without understanding what these repeated cycles are actually doing to the stability of the tissue.
Right. So when these polynucleotides enter the vulvovaginal tissue, they act as biostimulators.
Mm-hmm.
But they aren't just sitting there taking up space like a dermal filler.
No, they're active. They are actively binding to very specific receptors on your local fibroblast cells.
And fibroblasts are, well, if you picture the extracellular matrix, which is like the 3D biological scaffolding that holds all your cells together and gives tissue its strength, the fibroblasts are basically the construction workers maintaining that scaffolding.
Exactly. So the polynucleotides come in and essentially force these fibroblasts to work overtime.
We should probably unpack the mechanics of that communication, actually, because the sources note that these polynucleotides are often derived from fish, like specifically salmon or trout.
Yeah, which sounds crazy. On the surface, injecting fish DNA to repair human tissue sounds like total science fiction.
It really does. But it works because of how DNA is structured across all species. I mean, we aren't injecting the genetic code that tells a cell how to be a salmon.
No, not at all. We are utilizing the structural backbone of the DNA molecule itself. The sugar phosphate backbone of DNA is actually highly conserved across all living things.
Right, so when these fragments are injected, they lock into what are called adenosine A2A receptors on the surface of your human fibroblast cells.
And binding to those receptors triggers this massive biological cascade. It commands the cell to just ramp up production of two very specific things, type 3 collagen and type I collagen.
Okay, so type 3 collagen is the early responder, right? Like
Yeah.
the quick, flexible, wound-healing collagen that your body throws down to quickly stabilize an area.
Exactly. But the long-term structural steel, that's the type I collagen. That's what provides the enduring tensile strength.
But forging that structural steel actually takes a lot of time.
It does. A standard clinical protocol usually involves an initial loading phase. So that's like 3 to 4 treatments spaced a few weeks apart.
To saturate the receptors.
Yeah, exactly. This repetitive dosing saturates those local receptors and triggers sustained collagen production. But the peak of that intense collagen synthesis doesn't actually happen until about 8 to 12 weeks after the very first injection.
Oh, wow. So it's a slow process. The tissue is building itself from the inside out, which means it takes months to fully stabilize.
Yeah, it's definitely not an overnight thing.
It's basically the biological equivalent of planting a garden. You prepare the soil, you plant the seeds, and then you just have to wait for the roots to take hold. You have to wait for the growing season to actually see the structural stability emerge.
I love that analogy because once those roots are established, the resulting tissue is real, living, autologous connective tissue. It's yours.
But because it is real, living tissue, it is still bound by the body's natural biological clock, right? Like, it doesn't last forever.
Right. The newly forged collagen fiber matrix has a long half-life, sure, but it does slowly break down at your natural aging rate.
Which the clinical sources benchmark at about 1.U to 1.5% per year for adults over 25.
Exactly. Eventually, the fibroblasts kind of clock out and go home.
Which is why people need those repeated maintenance cycles every 6 to 12 months. You're periodically forcing the fibroblasts back onto the construction site to maintain the scaffolding.
Yeah, you have to keep giving them the blueprints.
So since this newly generated soil is constantly growing and then naturally degrading and then being forcefully stimulated again over the years, we really need to look at how clinicians are actively monitoring it.
Absolutely. The surveillance of this tissue is highly regimented. I mean, the vulvovaginal area is hormonally responsive. It's subject to daily friction, moisture, potential microtrauma. Clinicians can't just passively hope it stays stable.
Right. They rely on a standardized active surveillance checklist. Like during the active treatment phase, they evaluate the tissue at monthly intervals.
And then once that initial loading phase is complete, they perform a major structural check-in at the 3-month post-treatment mark. They're looking for a very specific set of localized tissue responses.
Let's run through those benchmarks.
Mhm.
The checklist includes tracking any pain or tenderness, unexplained bleeding, or bruising that refuses to resolve.
They're also looking for early signs of localized infection, the formation of hard nodules, and any sort of fibrotic scarring.
And the clinicians grade these responses on a scale from none to severe,
Right.
giving them a quantitative measure to track how well the tissue is tolerating all these continuous biochemical commands.
Yeah, it's very systematic, and it's worth noting that the broader safety profile backing up this class of medical devices is vast.
How vast are we talking?
Well, one of the clinical safety reports details a 5-year surveillance program that tracked over 300,000 uses of polynucleotides, and it concluded with an excellent safety profile.
Wow.
Plus, there are 24-month retrospective studies looking at intradermal treatments in other highly delicate areas like the periocular region, which is that incredibly thin skin around the eyes.
Right.
And those studies show zero delayed adverse events despite cumulative exposure to repeated maintenance cycles.
Okay, wait, let me stop you on those numbers for a second. Because 300,000 safe uses over 5 years sounds definitive, but we kind of have to isolate the variables here.
What do you mean?
Are all 300,000 of those uses specifically for the intimate area? Or does that massive data set lump in patients getting these fragments injected into their knees for joint repair or like their scalps for hair growth?
That's a very fair point. That data set represents the generalized safety profile of the purified polynucleotide molecule across all of its medical and aesthetic applications combined.
Okay, so the biocompatibility of the molecule itself is proven.
Right. However, definitive, large-scale, long-term trials spanning decades that are specifically focused on the intimate area, those are still emerging.
So we know the tool is safe generally, but we just don't have decades of data on what happens when we use this specific tool on this specific anatomy.
Exactly. Take something like genitourinary syndrome of menopause, or GSM. As estrogen levels drop during menopause, the vulvovaginal tissue physically changes.
It loses its collagen scaffolding, right? It thins out dramatically, the pH alters, and it becomes super susceptible to microtears.
Yeah, it's a huge shift, and this is actually one of the primary medical reasons patients seek out these intimate regenerative injections, to rebuild that lost scaffolding.
Which makes sense.
And we have highly promising pilot studies and observational data showing polynucleotides can repair GSM tissue. But we do not have the 30 years of longitudinal data that we have for something like traditional facial aesthetics.
And because the baseline architecture of GSM tissue is already compromised, you really can't assume that a molecule behaving perfectly in the healthy, thick dermis of a cheekbone will behave identically in thinning, hormonally depleted vaginal mucosa.
Exactly. Not without rigorous ongoing monitoring, which really pushes us into the mechanics of cumulative exposure.
Right, because when you introduce any repeated medical intervention into the body over years, you run into cumulative risks.
Right. As we transition from looking at the short-term healing to the long-term landscape, clinicians have to watch for signs that the patient's tissue is starting to, well, reject the repeated cycles.
So what's a major long-term benchmark for concern there?
One of the biggest is skin sensitization. Even highly biocompatible materials can trigger issues if you overwhelm the local immune system.
I mean, repeated exposure over long periods can cause the local tissue to become hyperreactive. And the sources say the risk skyrockets if a patient is stacking these polynucleotide cycles with other aggressive aesthetic treatments in the same intimate area.
Oh, definitely. Like stacking it with radiofrequency tightening or laser resurfacing without giving the extracellular matrix any time to recover.
But wait, I have a question about the sensitization. Because the mechanism behind this is fascinating. As we touched on earlier, this is essentially fish DNA.
Yeah.
So if it's fish DNA, Why aren't people just developing massive allergic reactions over time?
Okay, so before it ever reaches the clinic, the extraction process puts the raw material through extreme high heat sterilization and deproteinization.
The proteinization, that's the crucial part, right?
Yeah,
Because the proteins attached to a cell act like biological license plates.
that's exactly it. They are the identifying markers that tell a human immune system, hey, I am a foreign invader from a trout. Come destroy me.
So by stripping those proteins away, you're left with just the naked, unidentifiable structural backbone of the DNA.
Right. And without those protein markers, true allergic reactions are incredibly rare, barring a severe systemic fish allergy, which they screen for during the consultation anyway.
Okay, so the long-term sensitization they're monitoring for is not a sudden chemical allergy to the DNA itself.
No, it is a state of severe tissue fatigue.
The physical landscape of the anatomy just gets exhausted.
Yeah. You have the repeated mechanical trauma of the needle punctures tearing through the mucosa, combined with the continuous, intense biochemical signaling forcing the fibroblasts to build collagen.
That's a lot of stress on one area.
It is. Eventually, this can trigger a localized, chronic inflammatory response that just refuses to settle down. The tissue is overworked.
And that directly ties into another major risk benchmark identified in the aesthetic medicine protocols, which is dependency.
Right. But the protocols aren't referring to a physiological addiction where the body goes into chemical withdrawal.
No, it's a psychological dependency, where patients demand frequent top-ups far too close together. They might not see the immediate volumizing effect they expect, so they just ask their clinician for another round of injections before the previous cycle has even reached its peak.
Exactly. And if the peak collagen synthesis takes 8 to 12 weeks and a patient demands a top-up at week 4, they are overlapping the inflammatory healing phases.
That sounds like a recipe for disaster.
It is. They dramatically increase the cumulative side effects, the tissue fatigue, the swelling, the risk of sensitization, without yielding any extra biological benefit. The receptors are already saturated.
Which is why the guidelines are explicitly clear on this benchmark. Maintenance cycles should be spaced no sooner than every 3 months at an absolute minimum. The natural regeneration cycle needs space to finish its work.
Totally. And aside from biochemical fatigue, clinicians are also monitoring for catastrophic mechanical failures over time.
Like the formation of persistent nodules.
Yes, the most common mechanical issue. A nodule is a small, firm, fibrotic lump under the surface of the tissue. When this happens with polynucleotides, it's rarely an immune rejection.
It's almost always a mechanical pooling of the product, right? Like if the needle goes too deep or if the product migrates away from the target site.
Exactly. The vulvovaginal area is subjected to constant pressure and friction. So if the DNA fragments pool together into a pocket, rather than integrating smoothly into the extracellular matrix, the body just walls it off, creating a hard nodule.
Wow.
So tracking whether the tissue remains smooth and pliable, rather than developing these fibrotic speed bumps over the years, is a fundamental part of the 3-month surveillance check-ins.
So we're really looking at a progression of risk here. We start with tissue fatigue, move into the formation of mechanical nodules that alter the physical landscape, and that actually brings us to the strict escalation benchmarks.
Right, like when does a routine expected side effect cross the line into a medical emergency?
Because of the structural complexity of the intimate area, surveillance goes way beyond just the surface of the skin.
Oh, absolutely. The escalation protocols actually begin before a single injection is even administered. Clinicians must establish a baseline safety benchmark to rule out any undiagnosed pain, unexplained bleeding, active bacterial or viral infections, or suspicious dermatological changes.
Because you cannot use a regenerative biostimulator as a biological band-aid. If a patient comes in with undiagnosed vulvar pain, injecting a substance that forces massive cellular regeneration and inflammation could easily mask the symptoms of a much more serious underlying issue.
Yeah, you could be papering over an undiagnosed autoimmune condition, a severe dermatological disorder, or even an early-stage malignancy.
Right.
The absolute rule is that you never intentionally regenerate tissue over an undiagnosed problem. But once a clean baseline is established and the cycles begin, the patient is armed with post-treatment escalation signals.
And these are the red flags where the routine monthly clinic support is bypassed entirely and the patient is instructed to seek immediate emergency medical care.
Exactly. The guidelines list severe or rapidly worsening pain as a major one. We aren't talking about the dull ache of a needle puncture. We are talking about acute escalating pain.
And heavy active bleeding is an immediate stop signal too, along with any signs of systemic infection, which would present as a fever or a rapidly spreading heat and redness across the pelvic region.
Yes. And the final critical red flag, and this one is huge, is acute urinary retention or sudden incontinence.
Right. This goes back to the very first scenario we discussed, the anatomical context.
Exactly.
Because these injections are targeting the vulvovaginal and suburethral areas, and the urethra sits directly in this injection zone. So if a patient experiences an adverse reaction, say they trigger that severe tissue fatigue we talked about, or a massive inflammatory response, the resulting swelling is nowhere to go.
None at all.
It will literally physically compress the urethra.
Yeah, think about it. A millimeter of severe swelling on a jawline is, well, it's a cosmetic annoyance, but a millimeter of severe swelling in the suburethral hammock shuts down core physiological function.
It's terrifying when you put it like that.
Yeah.
The exact same molecule causing the exact same biological cellular response requires an entirely different universe of risk surveillance purely because of the geography of the tissue.
It really does. Acute urinary retention is a totally unique critical benchmark for intimate treatments. It demands emergency intervention to drain the bladder and reduce the localized swelling before permanent damage occurs.
And the surveillance never truly stops, does it?
No, it can't. Every single time a patient returns for a maintenance dose, whether it's 6 months or 3 years down the line, the clinician runs through the entire checklist again.
Checking for localized pain, slight changes in urinary function, palpating for deep fibrotic nodules.
Exactly. The cellular signaling never stops as long as the maintenance continues, which means the monitoring cannot stop either.
So to pull all these pieces together for this deep dive, we've explored the biological mechanisms of how these purified DNA fragments bind to the fibroblast receptors, forcing the construction of type I and type 3 collagen.
Right.
We've looked at the rigid biological timeline, where the tissue takes months to stabilize and then naturally degrades at 1 to 1.5% a year.
Yeah.
We've walked through the active surveillance checklists clinicians use to monitor this living soil for tissue fatigue and mechanical nodules, and we've highlighted the critical escalation benchmarks, like acute urinary retention, that arise purely from the unique structural complexity of the intimate anatomy.
The application of this technology requires a long-term, highly monitored partnership between the patient, the clinician, and the patient's own cellular biology. It is definitely not a quick fix. It is a fundamental alteration of how the local tissue behaves.
Which leaves us with a final provocative thought to mull over today. We're entering an era where regenerative medicine allows us to constantly command our cells to rebuild. We're using continuous DNA signaling to override the natural degradation of our tissues.
Yeah, we are.
But we really have to wonder about the long-term biological cost. I mean, if we spend decades keeping these intimate tissues in a constant state of hyperregeneration, forcing the garden to bloom year after year without ever allowing it to experience a natural winter, the cells eventually forget how to age naturally.
That's a great question.
What does the microscopic landscape of this tissue look like 30 years from now when the biological clock has been reset hundreds of times? Something to think about the next time you hear about the miracle of regenerative aesthetics. Until next time, keep digging deep.